My name is Richard Hunt. I am the Senior Medical Advisor for the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response in the United States Department of Health and Human Services. Welcome to the National COVID-19 Clinical Rounds for Critical Care, Life-Saving Treatment, and Clinical Operations. The purpose of these clinical rounds is a peer-to-peer real-time sharing of COVID-19 critical care challenges and successes in life-saving treatment and clinical operations. If I'm a physician treating a critically ill COVID-19 patient for the very first time, the physician I want to learn from is the one who has cared for the most COVID-19 critically ill patients. This is a voluntary public-private collaboration, and I want to thank all the multiple professional organizations who've collaborated by sharing their logo on the banner for this announcement and sharing the announcement and the information about how to access this webinar with their members. We have many, many experts in many fields, many disciplines, leaders in their organizations who have joined us as well. And we hope in future endeavors like this, we have you as discussants as well. Given that we're trying to fly the plane while we're building it, many of the questions that we've received, we're going to be triaging to the speakers at this particular juncture, again, realizing that in the future, we really want to have multiple discussants. Organizations have made extraordinary efforts in this national emergency to support their members. This effort is not intended at all to replace any organization's efforts, but instead be additive. Thanks especially to the National Ebola and Other Special Pathogens Training and Education Center. The operative words there are other special pathogens. They were always intended to support training and education for all special pathogens, emerged or emerging, and I think all would agree this one has emerged. And a special thanks to Project ECHO, the platform we're using for this very large endeavor here we have today. At this juncture, I want to turn it over to the director for Project ECHO, Dr. Bruce Strominger.
Great, thank you, Rick. And welcome everyone. It looks like there are over 1,000 people signed in already. And we know there are clinicians from every state in the US and from over 30 countries planning to participate in this really important clinical update. I'm going to share my screen and go over a few housekeeping items very quickly. Hopefully you can all see this. Just want to remind people to please reserve the Q&A function on Zoom for questions and comments regarding the presentations. We won't have time to go over all the questions, but we appreciate you sharing them, and we plan to review them over time and hopefully be able to inform what's discussed in future sessions. Please use the chat function on Zoom for questions regarding technical and logistical issues. The slides and a link to the video recording will be shared after the session via email with everyone who is registered. All the two presentations from our speakers have already been linked to the most recent reminder that went out, so you should be able to download those now if you check with the announcement. And please make sure you register through the Poll Everywhere QR code that I'll be displaying in just a moment so we can keep track of who's participating. The session's being recorded and your attendance is consent to be recorded. Thank you for that. There will be CME credits available through the University of New Mexico. We'll have a link in the chat at the end of the session, and we'll appreciate your feedback through the questionnaire. So here's the QR code that we hope you can scan and fill out your name and your organizational affiliation. That'll let us know who is actually participating in the sessions. We'll also share a couple of links during the session in the chat, and at the end, I'll display this code again so that people can do that later. With that, I'll stop sharing and hand it back to Rick. Rick, you're muted. Go ahead.
Thanks, Bruce. The format for this is we have two presenters. Each will be presenting for 20 minutes each, and then we'll have 5 minutes of questions that I'll direct to our presenters. Our first presenter, and I just want to say off the top, extraordinarily grateful for these physicians who have stepped in while they're taking care of patients to share their knowledge with all of us. The first presenter is Dr. Mark Caridi-Scheibel, Assistant Professor of Anesthesiology and Critical Care Medicine, and Medical Director of the ECMO program at Emory University Hospital. Mark.
Thank you, Bruce. Hold on 1 second here. I need to share. Okay. Thank you again. All right, trying to advance here. There we go. Thank you again. I'm Mark Caridi-Scheibel, critical care attending here at Emory University Hospital. My focus today is going to be on one of 3 COVID units that we have set up. It was a 14-bed, relatively new unit that I just happened to be attending in when this hit. A large amount of co-credit, though, goes to the 3 other attendings that were in other units that were coming online that helped develop these protocols, and a lot of other people in the effort. Some objectives. I'd say this is aimed for those directly providing care to critically ill patients. I'm trying to make some recommendations that we think are practical, common sense, and within standards of care. I think the outcomes are very likely to be based on your patient mix, locations, and resources. There's a lot of information here. I'm only going to pick out highlights out of some slides, but I hope you can review them later. But more than anything, what I really want to convey is that there is some hope and that there's lots of things that we can do better. So right from the get-go, our approach was really threefold. We recognized that failing any other reliable information, what we really needed to do was deliver great critical care with a high level of attention to detail. There is no luxury of time. We need to get these patients better and release the resources. And then practically, procedures should be preemptive, both because the patients rapidly decline and there's considerable delays with PPE and provider safety. I was hoping to speak a little more about organizational stuff, but it was too much. Very briefly though, leaders, attendings, managers, this is really the time to step up. Just anticipate long hours, just accept it. Really make friends, call in favors. And if there's one organizational thing that I think was really what got us through the week, I really encourage everybody before rounds every day to do a morning huddle. We took 15 minutes. Everybody in the room was involved, in the whole unit was involved. And it was incredibly helpful. We documented algorithms and protocols while you have time. It saves time later, and be very thorough with transitions. I just wanted to kind of review the disease course. Some of this has been described in other literature. This is kind of, and I think backs up our own observations. It's really kind of marked by these slow plateau phases that have very rapid and unpredictable transition. So what we did was we kind of organized our protocols around these phases, which will make sense when you see it. So phase 1 is the prodrome. It's a pre-admission. It's very non-specific viral prodrome, but it is marked by poor PO intake, and many people have nausea and vomiting. The second phase is been referred to as the silent hypoxia. It's the slow smoldering kind of illness. It's generally, we see, this is where what people are experiencing on the floor. They're usually on maybe between 2 and 10 liters of oxygen. And curiously, they don't feel much subjective shortness of breath. Objectively, they're tachypnic, but otherwise appear comfortable. The chest x-rays have been pretty well described, diffuse infiltrates. They do have noticeable difficulty mobilizing thick secretions, and they often require volume resuscitation for their lack of PO, but this is often overdone and becomes a problem later. This can last for days, though, before progressing, so you need to kind of continue to be very vigilant with them. Phase 3, I've kind of come to call the struggle bus. It will again kind of come on somewhat rapidly within a few hours. Their oxygen requirements start to go up, and they really subjectively start to feel it and feel anxiety and subjective shortness of breath. The coughing requires increasing effort, and this was our marker to kind of prompt a movement into the COVID ICU in the beginning of our bundle. The problem is this particular phase can last from hours to days, but you'll see our recommendations later for this. The next phase is respiratory collapse, kind of marked by requiring non-rebreather or other non-invasive ventilation or intubation to maintain saturation. This again will come on very suddenly within hours. I'd say the duration of this phase seems to be dependent on initial mode of therapy. Our typical intubation time has been 4 to 5 days. And I would say briefly at this point, I'll talk to it later, is that high flow nasal cannula and non-invasive ventilation seem to delay the time to intubation at the cost of de-recruitment, accumulation of secretions, and worse compliance. The respiratory phase is, it's ARDS without being ARDS. The unusual part is there's relatively normal compliance, even when needing high peak, moderate to severe VQ mismatch, notable pulmonary edema and effusions, initially apparent single organ failure, but there are other mild derangements and I think subclinical organ dysfunction, lack of shock, again, the thick copious secretions, waxing waning fevers, an AKI that likely is not really related to hemodynamic or volume status, which is important. And then we're kind of investigating is whether a rapidly rising CRP that seems to immediately precede failure. The phase 5 is kind of 2 alternate paths. They seem to, within a day or so, either rapidly progress to multi-organ system failure and death. We to this moment have not observed this in our patient set, but there is one patient that is now struggling who was one of the ones that kind of lingered on high flow nasal cannula for too long, I think. Elsewhere described as this hyperinflammatory phase that is also where the fulminant viral myocarditis has been reported with these malignant arrhythmias. And this is where, my colleague next in her presentation, I think, will address may be amenable to mechanical circulatory support if you have rapid intervention. By and large, what we've seen though is, with good care, is a resolution over several days to extubation with a rapid return to near baseline. Our decision points and actions, therefore, were, if they were on 2 to 10 liters nasal cannula, we cohorted to the floor or the ICU if they're particularly frail, where they received standard care, and generally we continued antibiotics until we confirmed it was COVID and no other infection by culture. Once it got to greater than 10 liters, though, or subjective worsening work of breathing or subjective shortness of breath, we did move to the ICU. And we did a number of things kind of right off the bat and preemptively. Everybody got a chest x-ray and an A-line. We started sending some surveillance labs. We don't always know what to do with them, but they've been kind of reported in the literature, and we're following to I think at this point, educate ourselves to what might be predictive. We're doing strict eyes and nose, not necessarily with the Foley, but we think volume status and tracking it carefully is important. And we also started doing aggressive pulmonary hygiene. We started empiric glifensin, and some of this was almost on par with cystic fibrosis therapy. Inhaled mucolytics is needed, aggressive incentive spirometry, flutter valve, et cetera. Once they get to 15 liters nasal cannula or requiring non-rebreather or increasing respiratory distress, we skipped high flow nasal cannula and non-invasive. At first, this was out of concern for transmission, but it became more apparent that I think in the literature and our own observations that especially high flow nasal cannula will mask progression of pulmonary damage by making the PaO2 just look better. In the meantime, allowing secretions to accumulate and continue de-recruitment so that when you did intubate, it was their function was worse. And likely, specific to BiPAP, it's likely actively harmful by newer Italian reports. So we proceeded with controlled intubation. They all got a central line, whether or not they were on pressors. We started surveillance labs, and again, strict eyes and nose. And we also, in kind of wanting to understand the cardiomyopathy, got baseline echocardiograms on everybody, whether that was bedside or by cardiology. And then we began our other kind of management features, which I'll go through by organ system. I'm just going to go through some highlights of these. I'll leave it to everybody to kind of look through the details. Neurologically, there's what we've observed is this marked encephalopathy and a delirium that resolves in about 2 days post-extubation, but their sedation requirements have been very high. That said, we tried aggressively to minimize sedation. We aimed for a RASS of -1 as respiratory status allowed. We understand that this was, it's uncomfortable for a lot of providers. It's inconvenient, but we really have to do it, and we believed in it. We put everybody in prophylactic restraints, again, recognizing that PPE is difficult to get into rapidly to, hold the patient back. And then once they were extubated, or even while we were still intubated, we pursued PT as rapidly as possible. Just to get some additional comments on the sedation. Just keep in mind that the cost, and we understand this from other studies in critical care, but particular to here, the cost of oversedation is prolonged vent time and delirium that the patient and the resource utilization we're under cannot afford. So I think whether it's uncomfortable, we have to accept some increased risk of recall, self-extubation, and just inconvenience that we normally don't, for right or for wrong. Pulmonary, we didn't have to do a lot of, none of this was magical. Lung protective ventilation, weaning aggressively, really staying on top of it. We favored PEEP over FiO2, IPA, the high PEEP ladder. Early paralysis, early inhaled vasodilators, and early pronation. They do seem to be very responsive to all of these. There's a lot of pulmonary edema that we noticed, whether or not they had other signs of peripheral edema. And so we really endeavored to drive them out. They also had pronounced secretions. We did a lot to keep on top of that. And when we extubated to high flow nasal cannula or face mask for 12 to 24 hours, just to be sure. Cardiovascular, again, maximizing perfusion, especially renal. We repleted lights aggressively. To prevent arrhythmias, and then we monitored closer to myocarditis. We had a protocol for following troponins and echocardiograms repeated as necessary. Renal, diuresis. The AKI that we've been noticing has not generally been pre-renal. We've seen a lot of ATN followed by an acute interstitial nephritis that we're kind of trying to look at more closely. Bedside echo can be really helpful in kind of helping to track volume status. And again, aggressively repeating electrolytes. And I would urge everybody to look at the goals that we set down below. GI. We did aggressive early feeding. We put a Daboff tube right away, took out any NG, and kept that post-extubation. We have not let them eat right away. A lot of them have had problems swallowing afterwards and continue to have delirium. So we've continued tube feeds in that setting. Lots of questions about ID and antiviral therapies specifically. We have, by and large, only been enrolling in the remdesivir trial. They're actively looking at other trials, but we've really let ID run this show. Hydroxychloroquine, unclear efficacy, and really it's about to run out. We are only using only if the patient is not improving and not eligible for the trial. Other anti-inflammatories, somewhat controversial. The only thing that I think we specifically recommend is that steroids are probably harmful, but sometimes you just have to use them for their other comorbidities. And just remember, COVID does not kind of preclude other infections. We have seen some super infections. What I'd say is leukocytosis and sustained fever really is indicative of another infection, and we urge watching cultures and new pressors additionally. What we found not to be helpful is, I urge people not to be experimental outside of a trial or accepted off-label uses. However unmeaning, just remind everybody it's unethical. Be careful with advice from people without direct experience. There's lots of well-meaning colleagues who are going to forward all sorts of stuff to you, and pick somebody to just kind of sift through it for you. And really try to stick to vetted material. We like the CDC. Reinventing the wheel with every change of attending. Really try to establish a consistent set of standards. It will save time. Just to see how successful this is, we've had 14 known positive, or I had last week, 14 known positive patients that were critically ill, variety of ages, variety of comorbidities, some very sick. 12 required intubation, 1 proning. Really haven't had to use a lot of rescue therapies. 5 have been successfully extubated with continued recovery. 4 are on the floor right now, and there's 1 more since yesterday. A lot on room air to just a couple liters. 2 more kind of smoldering, and 1 is actually kind of approaching, unfortunately, the death phase. But to date, we have not experienced death. I think to some, what we did was we have optimally, rapidly, and proactively provided really good critical care, regardless of the time of day, not just right after rounds. We intervened very early, aggressive monitoring, focusing on the good things that we should be doing all the time, and creating a set of practices and decision points that we can rapidly act on without having to think too hard about it. And really stick to your guns and hold yourselves accountable. Final thoughts, prepare early. It's gonna be really hard. It took a lot of effort. There's a lot of hope though, and I really want people to believe that. And it's very much worth the effort. The 5 people on the floor right now, I think really appreciated our efforts. And a special shout out to our team, my team from this week. They were amazing, and I can't thank them enough for their efforts, and the patients do too. And thank you.
Mark, thanks for a great presentation with a lot of information. I think is going to potentially save some lives here. So a couple of questions, and back to the questions for a moment. Yes, there are many, many questions. And as I mentioned, we received literally pages and pages of questions when people registered. We're not going to be able to answer all those questions for sure. And I want to focus questions to the presenters that are really just laser targeted on critical care, some big picture, preparedness issues too. So with that in mind, Mark, you covered a lot of the respiratory challenges in your presentation. A specific question around that. Does your airway management in COVID-19 patients differ from your approaches to other ICU patients? Again, airway management.
I think the specific management, not so much. We did take extra safety precautions, and we have, the anesthesia team, or I was anesthesia trained, so I've been doing a lot of it myself. We use video scope, and I think the more elective you can do it, the better it is both for the patient and the provider. So it was another argument for very early intubation when it was more controlled. We've done some other kind of safety things. We put, a bacterial filter on the ambu bag during pre-oxygenation and for initial bagging, and things like that. So a lot of it was very common sense. I don't think but I think early intervention is the key.
And one more time, your threshold for airway management in these patients, as in invasive airway management?
So really, we were on heightened alert once they got to 10 liters, and that's when we moved them to the ICU. We kept them on just, the heated, not the, Airvo or OptiFlow. We did not move to that, but we kept them on kind of standard humidified tubing up until about 15 liters. They would sit there for a couple days in that range, but, they would declare themselves. Once you got to 15 liters or non-rebreather, we just intubated. Right, and it kept it simple, and they went pretty, our experience has been if you do that, they tend to start with get pretty quickly to low ventilator settings and seemed to progress faster, where other people tended to progress more towards an ARDS picture.
Great, thanks. Another question. So, and this is a system question, operations question. And it's sort of a two-parter, but number one, what criteria are you using for COVID-19 patients for admission to ICU? And then what strategies are you using in your hospital if it turns out that the number of critically ill COVID-19 patients exceeds your current ICU bed capacity and capability?
Yeah. The first part is relatively easy. I think we've already triaged a lot of them onto a cohorted floor, so they're in general fairly well identified. We also have the unit attending has kind of had together with ID for ones coming right from the emergency room, had to make some triage calls. Sometimes if there's obvious other explanations for the respiratory failure. You still have asthma exacerbations, you still have kind of your run-of-the-mill CHF and things like that. So hypoxia alone didn't, qualify them. They had to have a good story. And just having the COVID swab was not always enough. So we did triage. But really, once they were on that, what we call the struggle bus, they got to that 10 liters. They were, obviously short of breath, or they were very frail and required close monitoring. That's when we brought them to the ICU. The second part of the question, sorry.
Yeah, no, keep going. Keep going. The second part of the question.
The second part of the question was, very briefly, they're, and this is kind of above my pay grade in general, but I would say that they've been planning this for weeks. The Emory Center for Critical Care, our director, has been really had this scheme of kind of progressive load balancing between the several hospitals within the system. So we have kind of serial, sequential transfers from outside hospitals to kind of keep it balanced. We also have a scheme within the hospital for sequentially taking over other units as we fill the current ones. We've already pre-identified where that's going to happen, and trying to have staff arranged ahead of to just kind of stay one step ahead of it. We have identified significant capacity, even to the point of like, are we going to take over PACU or other kind of non-traditional locations to set up? So we do have quite an extensive plan, and it's kind of on a rolling basis.
Thanks, Mark. I'm going to move. I have one more question that came in while we've been on this. Most of the other two I picked from the ones of the pages that we had received. I mean, in your experience in your unit, and thanks also to your team members, because I know they're contributing to the cause in a substantial way. But the question that came in, I thought is worth asking. All of them are worth asking, but this one in particular is important for your unit specifically. What have you observed and your team has observed has been the main, failure of the PPE challenges? As in your team, where's the vulnerable part with the PPE that you're observing amongst yourselves?
Hmm.
Is it the donning? Is it the face shield? I was like, is there a sort of like, oh, that's the one we really got to pay attention to?
Yeah, I think that's difficult. We had a really good, dedicated team of PPE trainers who really got us pretty up to speed very quickly. By and large, we have not had a terribly difficult time. I think where we've had problems, which wasn't really anticipated, was in people, associated services like X-ray, housekeeping. We didn't anticipate people coming to the unit who weren't really prepared for it. That we had to kind of give a little bit of just-in-time training and a lot of encouragement about comfort. There was a lot of fear that I think was, not that it wasn't unfounded, but had to be worked through. I think it was more of an understanding rather than the physics of putting it on. We did, the one thing I think is worth kind of considering is we did have a code on a patient that ended up being negative, but lucky because we did, in our usual system, it got announced overhead in the hospital, and a lot of people came charging in, and I think kind of heedless of the PPE. So I think having a very organized code plan is really important, and having it rehearsed and empowering the nurses and the APPs to really push people out who don't need to be there and really set up a gate. And we stopped calling overhead and have an alternate plan that's a little more systematic.
Yeah, that makes sense to me. Sure. Mark, thanks again to you and your team, and thanks to Emory as one of the 3 institutions comprising the National Ebola and Other Special Pathogen Training Center, the others being Nebraska and Bellevue. Much appreciated. Let me turn to Dr. Melissa Brunsvold, the Associate Professor for Surgery and the Program Director for General Surgery Residency Program at the University of Minnesota. Melissa, thank you very much for joining us, and welcome your presentation. Thanks.
Thank you. Thank you very much. I really appreciate the invitation. I wanted to say on your last question prompted me to think back. The governor of Minnesota just announced that there are, I believe he said either 4 or 5 physicians now who are positive in the state of Minnesota, and all of them contracted the COVID positivity at national conferences, none of them through direct patient care. So it's really important to be providing this kind of educational opportunity. I really appreciate what you're doing, and thank you for inviting me to participate in it. I would like to talk about our experience with ECMO and COVID. I did see Dr. Buckman chime in and give you a little bit of a props about your tele-ICU, and I had an opportunity to email with him a little bit about one of our patients this week, and so I would like to talk about that. Let's see here. I have no disclosures except to say that ECMO is an outside of cardiopulmonary bypass, is an off-label use of the technology. And it's a team sport. It's really important for me to acknowledge that it takes a lot of effort from nurses and bedside specialists, and quite a lot of people go into making our site is a Platinum Center of Excellence, and we would not be that way with all of the effort that goes into that. The case that I'd like to talk to you about is a 38-year-old male who's a marathon runner, so very healthy guy, no comorbidities at all, not a smoker, no vaping. He travels extensively for work, and he had a 5-day cough, and he went to a different hospital. There he had extensive viral testing, x-rays, everything was negative. COVID-19 testing was not available at that time. He was discharged home where, because he had traveled so much, he thought it prudent to continue to self-quarantine, which he did. He stayed isolated from folks. But just like Dr. Karidashev said, he presented again to our hospital sort of on this later period, about 6 days later, with a deterioration of symptoms, worsening dyspnea, dehydration, malaise. At that point, then, he had a fever. The Chinese experience also tells us that of the patients who are admitted to the hospital, 43% of those patients have a cough with no fever, and then 88% of them develop the fever then by the time later in the admission. So by that time, then he's saturating 90% on 9 liters face mask. He gets some azithromycin and ceftriaxone as a empiric therapy for community-acquired pneumonia. You know, he had people that thought perhaps not a viral pneumonia, but he had a classic ARDS picture on his imaging at that time. He had this rapid spiral, though, that we have seen is really classic and kind of the hallmark of the of all of the centers who care for patients with the coronavirus ARDS COVID disease, that it's this period of 12 hours or 24 hours where people really go down fast. And he became intubated, proned, paralyzed, inhaled epoprostenol, and his oxygen saturations continued to stay very low in the 60-70%, despite maximum ventilator settings and what we would consider all our usual ARDS rescue strategies that we would typically try for patients before considering ECMO. We, at this point, did not, this is our first COVID positive patient in our hospital. So we didn't have a dearth of resources or anything like that. This patient then is in the ICU. And we applied our typical ECMO criteria for him in terms of having a P to F ratio less than 100. And the other ECMO criteria would be if his pH was low, although for what we're seeing, as Dr. Krita just suggested, the patients are hypoxemic. The COVID patients are hypoxemic. They're not hypercapnic. So they're hypoxemic like this patient was. They go down fast like this patient did, but they're not hypercapnic. Many of the patients also, many other sites, the patients who go down fast like this are males, like this gentleman is, and they are also young. In the older gentleman, you know, our criteria, we would consider age. We would wonder about age if at extremes of age, but for this gentleman at 38, we made the decision to put the patient on ECMO. His PaO2 to FiO2 ratio was 61, so we chose veno-venous ECMO. And for those of you who are not familiar with ECMO, that drains blood out of the venous system. We used a Crescent cannula, which is a dual lumen cannula that goes into the internal jugular vein. The idea of ECMO is that it drains blood out of the venous system, runs it by a membrane, and then it has gas exchange across the membrane. Medical air and oxygen come on the other side of the membrane, and then there's gas exchange across. CO2 is removed, oxygen is added, and then it goes back into the venous system, and then goes into the heart and lungs as oxygenated blood. So that's what we did for him. And just prior to cannulation, the patient was reported to be COVID-19 positive within our system. So this is the patient's room. You can see it's relatively busy room. The patient was on the ECMO circuit, which is just behind here, and then also on CRRT, the nurse here with a PAPR, and then the physicians with N95 masks and gowns. And then it's a negative airflow room. The patient did get, we are a site for the hydroxychloroquine trial. The patient also had azithromycin. We're a site for the remdesivir trial, but the patient was in renal failure. So he got 1 dose, but he did not get any more of that. We're also in an NIH trial for angiotensin receptor blockers. to block the sites, but that works best if you're doing it in an early exposure. So he did not get that. And then he got an IL-2. So for cytokine storm, to decrease the amount of inflammation, you can decrease the amount of inflammation by blocking the IL-6 receptors with tocilizumab. So he did get that, and his IL-6 numbers did come down quite remarkably. So he was decannulated after a 12-day run. This is the first successful case of ECMO for COVID in the United States. He's still on mechanical ventilation, but he's recovering nicely. So the thing that I would like to discuss with you now is the need for ECMO in COVID. The need is really uncertain. And the reason for that is because we don't have a good model for it. In H1N1, ECMO was used 2.6 per million cases of H1N1. In MERS, it was used 5.8 times per 100 cases. There were 2,500 cases of MERS, so that's a wide variety. In ECMO in COVID, in China, there have been about 50 cases of ECMO reported so far. And here I pulled this down from the ELSO website. This was on the 20th. You can see 9 cases in London, 0 in Germany, 3 cases here, 18 cases in France. That's a high volume center, 10 cases in Spain. So places that do a lot of ECMO. Here's in Italy, there's only 12 cases going on these hotbed places. There's not a lot of ECMO. And yesterday in the United States, even though it's ramping up, there were only 33 patients on for, in a poll, in my poll through social media, or not in my poll, but my count. By my count, there were only 33 patients on in the whole United States for COVID disease. So it doesn't seem, and it seems like what we just heard also as well, is that the patients are hypoxemic, but they respond fairly well to conventional measures in terms of secretion management, proning, paralytics, epoprostenol, things like that. And they don't typically need to have mechanical circulatory support, which is a big relief if that's the case, because we're already short on the myriad other things that we have without having to plan, to put people, a whole bunch of people on mechanical circulatory support as well. So in thinking about planning, disaster planning at Minnesota, in 2013, this is a picture of the actual scene. A car went into a small retention pond. That car had 5 children and a mom in it. It was just an accident, nothing sinister about it in any way, just an accident. 5 children went in, and so 5 children presented to Minnesota Children's Hospital needing ECMO for near drowning. And so after that event, it totally overwhelmed that hospital. And after that event, we got together, the ECMO medical directors in the Twin Cities, Minneapolis, St. Paul area got together and did planning, considered planning about how to plan for disasters, including, at that time, we were all worried about Ebola or another influenza outbreak or something like that. And we put together a document, or contributed to this document, and you can take this down, Patient Care Strategies for Scarce Resource Situations. You can Google this, and it's free for anybody to download. That outlines our strategy for how we're going to handle a whole bunch of different situations. And one of them is ECMO. We planned this tiered response, 3 tiers for how we're going to handle ECMO in a disaster situation. And it's based on the duration of the run, so how much time we think each disease state would take, and the survival predicted for each disease state. So massive pulmonary embolism, for example, would have a fairly good survival, predicted survival, not the best, fairly good, so it's in the 2nd tier, and they have decently short runs, so that would be a 2nd tier short duration box. And the nice thing about the matrix is that it's very nimble. As disease changes, as we have improvements in critical care, we're able to move things around in the box. It doesn't matter where you are. If refractory VTAC, VFib for cardiac arrest, if we find an improvement or a worsening in the survival, your spot in the box just moves. And so then we, as medical directors, get together and say, no, that's not your box anymore. So what happens is, if my site is full, if we no longer have capacity at the University of Minnesota anymore, I call one of the other medical directors and say, we're full, we can't take a patient. Can you take a patient? If they say, no, we're full, it triggers the call to the regional healthcare compact, and it sets up this rotating call between us, the 5 medical directors who all do ECMO, and then we make decisions, again, based on that same triage box. So we all then will say, so and the next ECMO, rather than coming to our individual site, we have collaborated together, we all agree that we will make the decision for each other and we will abide by it. So what would normally be a competing hospital, medical director will decide for me whether or not I will take a patient, whether or not I will accept, and whether or not I'll put that patient on. We've all agreed that that's how we'll do it. So they will say, no, I can't take it, but that we'll send it to the university, or no, it won't go to the university, it's going to come to us based on the decisions in this box. And that goes for adults and children and neonates as well. So it'll rotate between the 5 medical directors on call. That's how we'll make our decisions. And then that model then has served in this time. All of the other disease states have wanted to see how we're doing it as they're making. This model has gone up through the command center as people are trying to decide how they're going to do all of the plans. And then the editor from CHEST has asked to see if we could, we've submitted this process to that journal. And then the other thing that we do is just share our data. So we have a REDCap database and we all put our information in. So we all know on a rolling basis how many patients are on ECMO in the Twin Cities area. You know, we're all trying to decrease. There's no elective cases anymore. We're discharging patients from the hospital. We're trying to get folks out. We saw, I should have shown you there's a decrease in hospital bed utilization that goes down like this. Our event days are still kind of flat. Our ECMO usage is still kind of flat right now as we're letting folks recover still, but these are, we know at any given time how many patients are on the vent or how many patients are on ECMO on our 5 ECLS centers around the Twin Cities area. So I think the beauty of this is it's very, very collaborative, and it's really cool that we're able to work together in such a really positive way. So this is us. This is me. Please feel free to tweet at me or email me if you have any questions at all. I'm happy to take emails or tweets. I'm just going to leave it up for 1 second and then I'll stop sharing. That's all I have.
Melissa, thank you. I appreciate it very much. And you touched on what everyone is challenged by, and that's, okay, ECMO, and then there's the issue of scarce resources and how are we doing that? And your organization ahead of time obviously is paying off. Some questions, and again, what I've tried to do is collect some themes. There are just great questions that are coming in. Yes, it would be great to answer all of them, but not manageable at this point. It's not like Grand Rails where you have like 4 questions. So a couple of questions for you. One, there's a lot that has been a lot of discussion in many different forums, papers, and so forth around cardiac manifestations and what's up with the sudden cardiovascular collapse and so forth. Can you share briefly your experience with the cardiac manifestations?
Yeah, so we have not seen the cardiac manifestations in our institution.
Huh.
What I have seen in the literature is that is predicted by an increase in D-dimer and troponins. It's pretty well predicted by those things. So we kept track of that. And for this gentleman as well, his D-dimers were very elevated in the beginning. So we did keep being concerned that was going to happen over time. I wondered if the anticoagulation of the ECMO was going to be helpful or protective for him in some way because of that. And so I wonder if one of the things people have said in the past is, could that be a viral myocarditis? I do believe, so some of my colleagues here have submitted to Nature. It'll be published, I think, coming up. It does not appear to be viral based on lack of infiltration at the cellular level. And so I think there's some greater, but it doesn't appear to be viral myocarditis. I think that there's going to be some greater understanding coming out about that. One wonders if it has to do with microthrombosis in the pulmonary vascular beds. So it's unclear what causes that profound cardiovascular collapse that happens at the late date. But again, it can be predicted by increasing D-dimers and increasing troponins. And so please watch for that, as well as a falling ejection fractions. Our gentleman never had the increased troponins and never had the increase in, or never had the falling, never had the falling increase in troponins, never had the falling ejection fraction. I do want to answer one question that you gave to Mark too. One interesting thing that our healthcare system is trying here, we have a 7-hospital healthcare system, and in order to save money, they had planned to shutter one of the hospitals, which was a long-term acute care hospital called Bethesda Hospital. You can Google on that, Bethesda Hospital in St. Paul. They'd planned to shutter that hospital, and in response to this pandemic, what they've decided to do instead is make it a COVID hospital. So our healthcare system is actually all COVID positive patients are being transferred to that hospital. And so that's how we're cohorting our patients. So persons under investigation will be cohorted on investigation floors in the other 6 hospitals. And then if they become positive, they'll be transferred to that one hospital. So they'll all be managed there. They'll have ICU capability there and general floor capability there.
Thanks, Melissa. And there are many alternate care solutions like you're suggested from your community that are like popping up very, very quickly. I have a couple questions, sort of lightning rounds, really quickly for both of you. Same question for both of you. One is, what labs are you using to inform your treatment plans? And Melissa, let's start with you because you already noted the D-dimer piece, but yeah.
So D-dimers, the infectious disease, so we're following D-dimers, troponins, The infectious disease folks are also following the CRPs and the IL-6s. We're participating in national trials for the IL-6 receptor antagonist, and we're following the, we're also participating in the Plaquenil trial that I mentioned. So those are some of the, that's why we're doing that.
Thank you. How about Mark? Can you unmute yourself and share anything different, or are you exactly the same in tracking on the labs?
We're similar. The panel that we came up with is daily CRP, CK, which probably we're going to let go of. It doesn't seem to be very useful. D-dimer, LDH. For the purposes of the remdesivir trial, we're tracking PT. Sorry, I think that's all of them. They're listed in my slide, but and then once they kind of get up, and once they're intubated, we're also following twice daily central venous stats and troponins. And again, we don't know what the utility of the frequency is yet, but we're trying to educate ourselves, I think, to see if we can pick up patterns in this. So far, we really haven't. We've seen kind of minor variability in troponins, but we haven't really found a pattern to it. And we haven't had anybody progress to complete cardiovascular collapse. So, again, but it is a prompt for us to follow echocardiographically and to see if there's any changes.
Thanks. And then I have another question for each of you, like lightning rounds, okay? Based on your experience to date, what are the most important questions remaining for critical care? Essentially, what are the most important research questions that we have for critical care for these patients right now? The ones that we really need answers to now. Melissa, let's start with you, and then I'll go back to Mark.
I think if we could, what's the most important question we could answer? If we could solve the problem of the late cardiovascular collapse, that would really be helpful. That's, I think, a very heartbreaking problem because the patients look really well, it seems, and then they seem like they get liberated from looking through the literature. They do have a decline that's not salvageable.
Thanks. How about you, Mark? Unmute yourself. Thanks.
Yep. Honestly, I think that just from a resource utilization point of view, it's predicting when is the appropriate time to put them on a ventilator and what is going to get them off the quickest. There's kind of two arms that have been kind of running. I think, people who are putting them on high flow nasal cannula and letting them wait for days to see if they recover spontaneously. And then people who are just like, I think on our end, who are just putting them on preemptively very early, which runs the risk of putting too many people on. But I think our current feeling is that it gets them off faster to put them on earlier. So I think that needs to have some resolution so we don't get, unfortunately, and it breaks my heart what the Italians are going through with having to make decisions where they're just stuck on that second arm without knowing who to really put on, who's going to benefit from going on immediately.
Yeah. Thanks to both of you for your presentations, your willingness to answer some really tough questions. Thank you. I'm going to turn this back over to Bruce Strebinger for a minute for some housekeeping issues, and then back to me, and then we'll close. Thank you.
Great, thanks. Thanks, Rick, and thanks, Melissa and Mark, for two fabulous presentations and for the discussion. I'm just going to quickly share my screen again, remind people, here we go, of some resources that they might look at. The NETEC resources found at netec.org. There are also some resources for healthcare professionals at CDC. And there's also technical guidance, WHO, that you might take a look at. For anyone that didn't have a chance to register their participation, if you can scan the QR code here, It'll just help us know who participated and allow us to send information back out to you, including the recording, a link to the recording of this session, so you can share it with your colleagues if you'd like to do that, as well as the PowerPoint presentations that Melissa and Mark both did. And remind you to take advantage of the CME credit and give us feedback on how this went and how you'd like to see this type of session improved in the future. So thanks again, and back to you, Rick.
Yeah, Bruce, we also had on resources that many of you have already accessed, but just want to remind you, certainly the CDC's resources, WHO's resources, and also NETEC.org is a really important resource that you should access if you haven't already. I want to note that there are so many questions. I see colleagues on these tiles that I've worked with for decades who I know have, jumping out of their seats wanting to have provide input and make sure that people are informed. Every organization is working really, really, really hard to address this national emergency. This, again, is not to replace any of those efforts, but intended to be additive. I want to note that the questions that have been posed already, the pages that we received already, have been forwarded on to the Healthcare System Task Force, and which is within the ESF8 structure for our national emergency. So they're very much aware of the challenges you're all facing. I don't see a practical way to answer every one of these questions, but note that we understand these are real important things that we all need to address, and it's a matter of triage at this point. And I hope people will bear with us while we try to do that. The last thing I want to say, so what's the future? Are we going to do any more of these? At least from my perspective, it looks as if, this, well, certainly I learned so much, and I think others probably have as well. Our hope, without any promises, would be that we could continue this series on a regular basis. Yeah, it would be ideal, maybe weekly for critical care, but we also want to make sure that in this public-private partnership that we actually address other pressure points. In the corporate world, they'd say pain points and so forth. Everybody's got pain for this. But I think other areas that we certainly have an interest in addition to critical care, would be the emergency department, and also certainly EMS. Alternate care sites are going to continue, as Melissa mentioned, her initiative there. The approaches that have been planned about for years, now we're actually implementing them, and how can we maybe address those as well in a forum such as this, where many across the nation have the opportunity to learn from each other in ways that they hadn't previously. So that's a vision. I'm going to be working with leadership here at HHS to see what is a way that we can path forward to continue what I think is a really valuable learning, again, in the spirit of having those who have seen this the most share their knowledge with those that haven't to date or are just beginning. The other thing I think it's really important to note, we have many disciplines represented here. And you could say, well, critical care, how does that relate to, for example, an EMS provider? Well, as this progresses with the numbers that we're seeing, many will be called upon to do things that they hadn't before, and we need to make sure this is accessible to all. With that, I'm going to end, and I am deeply appreciative to everyone who has participated, especially our presenters, NETEC and Project ECHO. With that, thank you so much for your kind attention, and best to all of us. Thanks. Bye.